Hey class, this is Professor Turpin. I'm going to try to continue and finish out the rest of this cancer lecture so that you guys have a little bit more detail. Hopefully it won't take too long. Um, as we talked about in class, there's multiple modes of therapy that is provided when somebody is diagnosed with cancer, and chemotherapy being one of those. There are several factors when you're giving chemotherapy that determine whether what is the response rate. Mitotic rate of the tissue of origin is how fast the cells multiply is the mitotic rate. So the faster or more rapid the rate of cell division, you actually have better response to chemotherapy. And that's sometimes kind of a hard thing to kind of get in your head. But if you think about it, you're giving chemotherapy and it's in the blood. And if the cells are rapidly dividing and getting killed, then you're killing off more and more of them at one time for the chemotherapy. If the chemotherapy is given and the rate is very slow, you're not killing as many cells, and then later on you have time for it to kind of resurge and grow back. So just a weird thing to think about. The other thing is the size of the tumor will affect how well chemotherapy works. The smaller the tumor, the better the response to chemotherapy. And the age of the tumor, the better response to chemotherapy. So thus the whole idea of if you have types of cancer therapy that have a very rapid cell division, but you catch them very early when the tumor is small, hasn't been in the body very long, then you're much, much more likely to have a positive effect from chemotherapy. Other factors that affect whether chemotherapy is effective is the location of the tumor. Very few chemotherapy agents will cross the blood-brain barrier. So if you have cells in the brain, for example, very few chemotherapy agents will work on brain cancer, and that's just part of the reason why. Sometimes you have presence of resistant tumor cells, and then when those become resistant to chemotherapy, then when they cell divide and replicate, then the daughter cells of those resistant cells have that resistance also, and then it continues to pass on to where now you've had certain chemotherapies like I was speaking about in class, and now you have to switch to some other agent because it's not really any longer effective on those cancer cells. Some tips in terms of really trying to handle chemotherapy. Chemotherapy is supposed to be really handled with nitrile gloves, specific waste receptacles that these have got to be disposed of in. So you can't ever take a chemotherapy bag down with your regular gloves or barehanded. You have to use a very specific, very thick, extra protective glove. And those are available typically in units that administer chemotherapy. In their soiled utility rooms, you will usually find a specific waste receptacle for chemotherapy agents. And it's not like the bloodborne pathogen stuff, it's totally different container. These drugs, the reason for this is these drugs can actually be absorbed through your skin. You can inhale these during preparation or carrying these drugs also. So they're usually kept in Ziploc bags for transport. And only people that have technically been certified or trained, by a specific facility should even handle these drugs, to administer them, to carry them from place to place or anything. So any agency that's you're going to work in, they're going to have you go through a certification course to be able to do this stuff. These are the different methods of administration. They can be oral, IM, IV. intracavitary, intrathecal, intraarterial. There are major concerns associated with IV administration of chemotherapy drugs, and you'll hear the term anti-neoplastic, and that just a neoplasm is a cancer cell. So anti-neoplastic means anti-cancer cells. But IV administration of these, if they were given directly into peripheral IV sites, can really be problematic. But there are some patients who just if they're going to have a short treatment, or they just are so high of risk for infection or something, they may opt to just not get like a portacath or a central line placed. So you have to be very, very cautious with giving these drugs if they're going to be given peripheral. If they infiltrate into the tissues, you can have severe, severe local tissue damage, and I'm going to show you some examples of that. Here is a hand where someone's had an IV in and gotten a chemotherapy agent that caused infiltration. And so when you think about the chemotherapy is going to kill good cells and bad cells, if it's not in a vein and it's in the tissue, this is kind of the result that you would have. So you can imagine this can be very difficult to heal. So if for any reason you have a patient that would be having IV meds through peripheral sites, if you see the least bit of swelling or anything, you immediately stop that infusion, take it out if it's infiltrated, and try to notify the physician so that they can be aware of that complication. This just goes into more detail about drugs being irritants or vesicants. Irritants can cause the inside or the intima of the vein to be irritated. There are a lot of drugs that we give with chemotherapy sometimes that cause just the veins to be irritated on the inside wall. Vesicants, on the other side, they really cause local tissue breakdown and necrosis, as you saw in the picture just prior to this. So if you are trying to find out the severity of the drug, you'd want to know, is it an irritant or is it a vesicant? Now, an irritant may cause the inside wall of the vein to get irritated, and if you're giving constant medication like that, then it may eventually wear the vein out to where you do get an infiltration, but it's mostly going to be very painful, and the patient's going to tell you that it's, that's burning, whereas a vesicant can cause that a little bit as well, but it's just really going to cause a lot of tissue damage. It's really important to monitor for and really recognize these symptoms when they say the term extravasation. That means where it is infiltrated under the skin, and if it's a vesicant, you have to take immediate action if that occurs. And again, the infusion should be immediately turned off, and if any swelling presents, there are going to be protocols for drug-specific extravasation procedures that are to be followed to minimize further tissue damage. So again, you go to your protocols, see what's there. Sometimes there may be different drugs that maybe are injected into the site to help with that, but just know that those are some of the things. You have to turn it off immediately and really try to take action based on the type of drug that it is. This is just some other methods of administration. You'll hear people talk about vascular access device. This is what a portacath looks like. As you can see under the skin, it's just a little receptacle that has kind of a central port opening, and attached to the back of it there is a catheter that then is threaded out the back of it and threaded into a major vessel that goes closer to the superior vena cava. And so therefore it's an excellent thing if it's accessed with a needle to be able to draw blood, as you can see on the picture on the left. It's great if you're going to have to give treatments frequently or continuously. And it's much easier if you're giving some of these really strong drugs that are going to have an impact on a smaller vessel or have a risk for being a vesicant. And you can also give fluids, blood, electrolytes, all kinds of fluid administration through these. You notice in the picture on the right there is a PowerLock safety infusion set. It has little wings on it and a downward needle. You'll hear people refer to this as a PowerLock needle, or some of them that are not PowerLock, just plain needles, will be called Huber needles. And a PowerLock one is going to have that yellow color and be designated as that. And if you have a PowerLock infusion set and you have a power port, as you see in the picture, those can withstand the pressure of a CT infusion power injector. And so you can imagine a lot of cancer patients sometimes need to get repeat CT scans with infusion to see the size of the tumor or the area where there is cancer. So it's really best for cancer patients to have a power port put in, not just a regular portacath, but a power port. And so you want to find out for sure, is that power port, is it a power port or an older portacath? Number one on your assessment. And then if it is a power port, you always want to put in a PowerLock needle, because then you always know that they can easily go get CT scans with infusion during that admission. Otherwise, they'll have to have a large bore needle put in, an antecubital, just like anybody else would have to have for power infusion of contrast dye down in CT. You can also get chemotherapy regionally. This is where drug is delivered directly into this tumor site. Sometimes this is really helpful when there's higher concentrations of the drug can be delivered more to the site of the tumor and cause less system toxicity, on somebody who's extremely weak or can't tolerate the chemotherapy going through the bloodstream. These are some of the types that you would see. Intraarterial. This is where it's not going through a vein, but it's going through an artery that is supplying the tumor, blood supply to the tumor. And sometimes they will give a chemotherapy agent through that artery to really tear up the artery that's supplying the tumor to grow. And then that way it cuts off the blood supply, and then the tumor may die from lack of blood supply to it. So that's one method. Another way is intraperitoneal. We've talked about the peritoneal cavity already, but this is where you deliver drug into the peritoneal cavity, and you will let that sit in there or dwell in there, they say, for 1 to 4 hours. So they may have like a catheter type device that's hooked into the peritoneal cavity. They instill the medication in there. They let it sit or dwell for 1 to 4 hours, and it usually may be 1 to 2 liters of fluid. So you're talking about a lot of fluid being in your cavity. And then they will open up the valve on that tube and then let it drain back out. And of course, that's something that you have to be very cautious with in terms of how you are, gowned up and gloved up to handle that. And here's a picture of what that looks like. Other methods, intrathecal. This is where they do a lumbar puncture and inject chemotherapy into the subarachnoid space. They can also give it intraventricular, where they are giving it directly to a ventricle of the brain. We talked a little bit about that a lot of these agents won't cross the blood-brain barrier. So because of that, they may have to give it directly into the brain ventricle itself when it's a brain tumor. And then last of all, intravesical. You'll hear that talk about when people are getting same thing like cancer treatment through their bladder for a few hours and then drained.